Hello, Instagram. By the way, the Instagram thing is not moving. Oh, that's my face. Hi, this is Elliot Fishman. I'm coming to you live on Facebook. I don't look like I'm so live on Instagram, but so this week Facebook is up. Last week, I'm sure some of you know that we recorded it, which actually it came out okay, but Facebook was down for a day. I think the world was coming to an end. I did notice that productivity was up like 30% last week on Thursday because nobody could use Facebook, and so everyone had to actually read films and do their job. Anyway, it's mid-July. Our new fellows, our new residents have started, and I'm sure in your practice, if you're an academic, the same thing is true. And if you're in private practice, you probably got some new partners. So hope everybody is moving along. It's always that change that is somewhat painful, but works over time. And what I chose for a topic this week was on pancreatic cystic masses. For some reason, I thought I was speaking about cinematic rendering, but pancreatic cystic masses it is. And I just wanted to talk about several things that are important. So first of all, we know that pancreatic cystic lesions are very common in patients over age 50. We tend to see them in 3 to 5% of patients. And we published that article years ago. The better the scanners are, the faster, the more carefully you look, the thinner your sections, the more cysts you see. And remember, people have said that on MR, if you look carefully, cysts are in 20% of patients. So they're not uncommon. The thing, of course, is the management of pancreatic cysts. There's a whole ACR thing, Alec Megabo wrote, which is really good in how to follow cysts. And they talk about following them for 10 years. Though I think there really is no magic time, nor is there a time when you can say you can stop following. I think Alec and the guys chose 9 to 10 years because they figured they can rewrite the article in 5 years when they have more information. 9 years gives you a lot of leeway into not having to worry and yet following patients. And then along the way, we can see what things occur. Are there going to be new markers in cyst fluid that allow you to be certain of what's going to be benign and what's going to be malignant? There are a lot of things. And one of the things we are looking at actually is AI with cysts. So several questions we want to ask. The most simple one is, can you distinguish between the various cysts? IPMNs, main duct IPMNs, MCNs, serous cystadenoma, lymphoepithelial cysts, you name it, cystic neuroendocrine tumors, cystic adenocarcinomas. The question is, can you distinguish between all of those tumors? And simply saying something's a cyst is, of course, a nice thing, but being more specific becomes very critical. Certain things help us: age, middle-aged female, body of pancreas, MCN. Cystic with rim enhancement, essentially always going to be a neuroendocrine, cystic neuroendocrine tumor. So there are things that help me and things that I look for. The other thing I wanted to comment about was this whole area of AI in the pancreas, specifically in pancreatic cysts. And so what people now are using AI for is trying to determine, particularly with the radiomics, can you distinguish between the various cystic lesions? Does each of them, even when they look somewhat similar, have their own signature? Okay, so that becomes a very important thing. And there's an article published, and it's in the list of articles on CTisus in the AI section, but it talks about distinguishing serous cystadenomas from mucinous neoplasms. Now, as I said, usually that's not a problem. Mucinous, middle-aged female, cystic, maybe a calcification, maybe a septation, usually not a dilated pancreatic duct. Serous cystadenomas tend to look much different. Common in the tail or head of pancreas, can be cystic with sort of like a sponge type configuration, often with a central calcification. We know that serous cystadenomas, and I think today I'm going to lecture on that. I'm going to record a lecture that'll come out in about a month or so on CTisus, which talks about the variations. And we published an article about that, Linda Chu and I, a number of years ago. But the fact is, serous cystadenomas can also have vascular rims. They can be stretching the vessel. They can be oligocystic, so they don't look like a serous cystadenoma when you think about a sponge, but they can be one big cyst and can be confused. I was looking at a case of 12 cm cyst by the tail of the pancreas recently. I've seen other ones with large cysts, both head, body, and tail, and I think it can be somewhat tricky from a differential perspective as a radiologist. So the goal would be is, can we have AI look at more features, particularly looking at the density, looking at the cyst wall, looking at the relationship of the cyst wall to the normal gland, looking at any enhancement, looking at any nodularity. All of those things would be very helpful to me. And I think hopefully AI can bring that out. And again, the focus is on radiomics. And there's one article that was published maybe a week or so ago, a little more than a week ago, actually had really good results. So we're trying not to yawn, I'm sorry. we're doing this as well. Linda Chu, Ian Parks, Tomi Kawamoto, myself are looking at our cystic lesions, looking at the ways of using AI to help distinguish between the various lesions. The question always, of course, is, do you add epidemiology factors, age, sex, location? All those things could prove to be helpful over time. I think one of the things we need to do, of course, that AI will help drive us is gathering all the data. You can't say I have a 7 centimeter or 3 centimeter, 2 centimeter cystic lesion. That only is really scratching the surface of information. We need to have more information about, correlation with age, enhancement, perhaps fluid density, perhaps texture mapping of the fluid, perhaps dual energy of the fluid. There are so many things we can get information on which we don't get information on. And all of that stuff would surely be very, very helpful, I think, to us. Now, people do ask, how do we manage things here at Hopkins? And I've made this comment before. We do have a cyst clinic. We meet every other week to go over the difficult cases. We treat patients depending on a number of things, including family history. If you have a family history of pancreatic cancer and 2 first-degree relatives, your chance of pancreatic cancer is much higher, 500 times higher perhaps. So those patients, you'll always get EUS after the CT. Even if the CT looks relatively benign because you're concerned this lesion could be one of the early lesions or the earliest appearance of a lesion. We talk about cystic lesions in older patients. I'm not sure what the older patients mean. I think a critical thing is that if we can, what patients should we not follow? If a patient's 85 and they have a cyst and it looks not very aggressive, are you worrying what's going to happen 10 years from now? Things like the EUS or even surgery, all of those things can be kind of difficult for some patients. So if a patient is not a surgical candidate, do you really want to be chasing that cyst down? And if you biopsy it, what is going to make a difference if you're not going to operate the patient? So there's a lot of thought going on with pancreatic cysts, how to manage the patient based on demographic, age, sex, comorbidities. You have a bunch of comorbidities. I think, do you want to operate on someone? So if you're not going to operate, why are you pursuing this? What looks benign, should you follow it? When should you not follow? There's been a couple of articles recently about screening in older patients. Again, what's an older patient? 75, 80, 90, 100? Should you not screen patients with mammography, with PSA, you name it, as patients get older? If you're not going to do anything about it, if their expected lifespan is less than the expected incidence of the tumor being problematic, perhaps you need to use some common sense. So I think cystic lesions of the pancreas are maybe a good way of thinking about our rules and how we do use the rules in terms of management. And I think as radiologists, we need to think about that as well. Simply saying advise correlation, clinical correlation, or simply recommending follow-ups on every cyst, is that really the right thing to do? And then, of course, you get into the discussion about how often do you repeat the studies. I mentioned that Alex said you need it for 9 years. They were saying do it yearly. With high-risk patients, you might do it bi-yearly, and then maybe you stretch it out, but the risk doesn't decrease over time, and that becomes a very important factor. So if you're having this high-risk patient or this high-risk population, perhaps you really need to think differently about that. So in terms of protocols, people do ask, how do we do cyst protocols? I would think surely the first time you want to do dual phase imaging, thin sections, 3D mapping. We are also now doing a protocol, very limited pancreas only, to decrease the dose. It's been shown, or people seem to be concerned now about MR, detecting early cancer. MR is stupendous for picking up cysts, but maybe not so much with cancer. So perhaps what we should do is screen with CT. Typically CT, we go diaphragms, maybe at symphysis, maybe at the crest. You have high volumes. What if you targeted a small area? I've calculated out the dose. Obviously, the smaller area, the less you scan, the less the dose is to the patient. And perhaps we can get the dose low enough that doing a CT would not be a bad way of screening some of these patients who will get scans every year or so. And so we're looking at that both for lesion detection as well as feasibility. And we have a special code now, and people who are involved with these patients with family history of pancreatic cancer, we'll be starting them, and we've done a couple of this week. So we'll let you know how things go. I was mentioning that I like dual phase. I like dual phase for anything, but on the initial evaluation of the cyst, dual phase is really good. If there's any rim enhancement, like neuroendocrine, it'll show it to you. If there's connection to vessels, if there's any invasion of local vessels, this will show it to you. I think the dual phase is really good to get a baseline. Now the question is, do you always need a dual phase? That's a different question. I think if you're only worrying about a cyst, probably cysts are better seen or better measured, surely, in terms of margins in the venous phase. So you may not need to do a whole elaborate follow-up, but again, it depends on the situation. But I think we are learning perhaps to be more conservative, particularly if patients are going to get multiple scans. Now, let's see. I thought I could answer some questions if anyone has any, but I could say hello to John across the street in Body CT, and you who's home listening and learning and eating lunch, it seems to me. If anyone has any specific questions, I can answer them. What other things do I think about with pancreatic cystic lesions? I think about this whole comparison becomes very, very important. Again, you want to, I am not always that aggressive if things look very simple, though the patients tend to be referred here and there's a cyst. The EUS people tend to like to sample it or look at it a bit closer. You know, it's kind of okay, but most of the time you probably don't need it. But it is a strategy of one way of separating out what patients have malignancy. Now, obviously, if patients have a cyst and have pain and weight loss or any symptoms, those lesions will probably be resected because of the comorbidities involved. But if it's only just a routine exam and your routine physical type study, I think you don't need to worry about it. Now, let's say Francis Gray asks, what age group is most frequently by pancreatic cyst? Well, I think with pancreatic cyst, the way you have to think about it is like renal cysts even. The older you get, the more cysts you will find. And I think the group I worry about are the patients in the 50s and 60s. As patients start getting significantly older, I tend to worry less based on their age and the chance of that becoming something problematic. If you're in your 50s and you have a cyst and it's reasonable size, or even it's small, you do always worry what's going to happen in the short term. And for that patient, short term might be 10 years. So that's why the sampling, and some people are aggressive on removing on borderline lesions. That's where it all comes about. I think we need to be careful in terms of our medical course not to be getting EUS on everybody where it's not going to add more information and it's simply going to confirm what CT said. So you want to be careful in that regard and use the studies as they're needed as they can answer questions. Let's see, speaking about questions, I have about 30 seconds to go. What else? I do like multiplanar. I also like with the cysts, if you put a line through the long axis of the pancreas, you then have like a coronal, or it's kind of an oblique maybe, of the gland in its entirety. It's much easier. I think people miss cysts at the edge of the lesion and in the edge of the head. They do overcall cysts all the time, and people often miscall small fatty lipomas when they're really tiny. Cysts, they can look similar. People often at times will now measure things, and they'll just do partial averaging. And some of the lobulations around the gland, they're not going to be soft tissue masses, but fat. So that's my time. We are writing some stuff. I'm going to be putting a bunch of stuff up on CTisus, on pancreatic cysts, in the next couple of weeks. Take a look at it. Let me know. And if you got any more questions, just come back and let us know. And we'll be back here 1 week from today, next Thursday. See you then. Have a great day.